Ooh. So, hello.
Hello.
Hello, how are you? You okay?
Yeah, and you?
Yeah, good, good. I love the backdrop. I'd just go for the plain blurry one. Um, okay, so I've marked the safeguarding work you submitted. There's two little bits I need you to add on to, but they're very, very small. If you give me 1 second, I will go on to,
Okay.
yeah, one of them is literally you just need to add the name of the person for a data who was your designated safeguarding lead.
Yeah, I've done it this morning, and
Okay.
it's Victoria. Do I have to mention her name?
You literally have to put a name down.
Okay,
Yeah. Uh,
that's fine.
um, so all it is for that part, it's that we need to we need to be able to see that you know who it is. So not just what they do, but who it is for your organisation. And I think there's one other very small detail, but it's all clearly written on the feedback. What I'm going to do is go
All I
through.
need to do
Ooh,
is just write her name, and I'll
yeah,
send it. Okay.
that's literally it. So it's two tiny bits, but I know you said we were at work, so I couldn't get in touch with you at the time, unfortunately. Um, okay, so looking at where you are in terms of the work, let me just get this.
10% out of 70.
What was that? Sorry.
10% out of 70.
Yeah, it'll be higher than that. We got some stuff that we can put into it. Um, Plus, once you've literally added those two bits, that's going to be another four or so percent. So we're still ahead. We're getting there. Okay, let's have a look. Uh, okay, so I can see here that you've not completed the promote own continuous personal and professional development unit.
Sorry, which one?
So the unit is ACM3. If you give me 1 second, I'll share my screen so you can see what I'm looking at. Okay, let's go. Okay. Can you see that one?
The first one.
Yeah.
I was never told to do it. That's why I didn't bother.
Okay, okay, okay.
Yeah.
What I can do is have a look. Do you have your rota for next week at all?
Um. Yeah, I think I have Thursday and Friday off on
Yeah.
that day,
Okay.
on
Let me
that
just.
week.
That's what I could do if it helps you. You would need to do a bit of preparation for it. Is I can go through this with you verbally, so you answer the questions through a discussion.
Sorry, which number are you talking about? Is it the first one?
Yeah, so AC M3, promote own continuous personal and professional development.
Sorry, I'm using my phone to be
It's okay,
sure.
it's okay. No trouble, don't worry. Um,
Okay, promote on continuous personal. Okay.
okay. So
Yeah.
what we could do, obviously we'd need to arrange like a time that we can get it done, is, and it also gives you time to prepare for it, is we can get you to talk through your answers instead of writing it down.
Okay.
Now, in order to do that, though, you're obviously going to have to read through the questions and make sure you've got your responses ready. So, for example, what I'd do is I'd give you all of these questions, send the information to you, and then basically go, okay, you revise and practice, and get yourself ready, and then next time I come and see you, I'd on a call, I go, right, okay, can you describe your duties and responsibilities? And you'd say, I do this, 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 and I record it and I type it down, an overview of what you've done, and then that gets this bit done.
Okay.
Right. Now, in order to do that, though, you're obviously going to have to, because it's CPD, it's all about reflecting on things that you've done. So you need to be very sort of like specific about things that you've done and how it's helped you. Okay. Would you like to do a quick overview on this part so we can prep you for it?
I think with this expectations of own expectations. So it's more or less all about me, right?
Yeah.
Okay.
So it's all about CPD. So how do you learn? How do you grow? Tell me about times that you've learned from attending a learner session. So it could be you've done induction training or you've gone out and had specialist training for peg feed. It can also be things like feedback. So feedback from your clients, feedback from the office and supervisions, spot checks, and it's essentially getting you to think how you've grown in your position, how you learn, and the benefits of learning.
Okay. All right, that's fine. I get it now.
Are you okay with that then?
Yeah.
Okay, right, I'll go from there. Okay. The next bit that we've got, I know you've done the safeguarding. After that, it's then ACM10, which is somewhere in here. Oh, where is that now?
So after the ACM3, which one again?
ACM10.
M10. Okay.
Yeah. So it's still kind of covering safeguarding, but it's looking more at things like mental capacity. So
Okay.
what I'm going to do is I'm going to share the screen again, but I'll share the PowerPoint we've got. I'll also send you some resources that we've got for it. Okay. Share what sound. Okay. Have a look. Slide. No, not new slide. I don't want new slide. I want view. Sorry. Okay. Okay. So this is the unit. It's ACM10, understand mental capacity and restricted practice. Okay. So the whole concept is to understand the learner outcomes, is to understand the principles of mental capacity in adult care, understand applications and principles of mental capacity and consent, and understand what restricted practice is. So this is the PowerPoint that you can get off the Quals Direct website as well. Okay, so first bit we got is a quick video which is covering what mental capacity is, and I'll give you an overview.
Welcome to this mini-gem. I'm a patient, get me out of here, a guide to mental capacity assessment. My name is Fionnuala Johnston, and I'm a geriatrics trainee in the Northern Deanery. By the end of this mini-gem, I hope that you will know what mental capacity is, why it matters, how to assess it, and what to do next if your patient lacks capacity. Mental capacity is the ability to make decisions and understand their consequences. People are allowed to make reckless decisions as long as they don't break the law. In the past, people with the best of intentions have decided that because someone is old or has learning difficulties, they are not able to make decisions for themselves. This sometimes resulted in people having their movements and access to loved ones restricted against their wishes. The Mental Capacity Act was established in 2005 and protects the rights of adults of any age to make decisions for themselves. It follows 5 basic principles. Firstly, capacity is assumed unless proven otherwise. Secondly, people should be helped to be able to make decisions for themselves. Thirdly, People are allowed to make unwise decisions. Fourthly, decisions made for people who lack capacity must be made in their best interests. And finally, decisions made in patients' best interest should favour the least restrictive option for the patient. To put the principles of mental capacity into context, I'd like to share a clinical case with you. Over a hot summer, an 81-year-old lady had a 6-week history of increasing confusion and self-neglect. She began to wander at times and leave the gas on when cooking. She was eventually admitted following a fall, unharmed but unkempt. She had previously been fiercely independent and had said that she would rather die than go into a home. She had a very caring and concerned family who were convinced that she had dementia and that she was unsafe to go home. They felt that she didn't know what was best for her and that they couldn't look after her anymore. They were keen to get her out of hospital as quickly as possible and wanted us to sort out residential care straight away. So what happens next? Should her family decide where she goes? How do we determine whether or not she is able to decide? You've already learned that we must assume that she has capacity until proven otherwise. To assess her capacity, we need to give her information about the risks and benefits of going home. She must be able to understand and retain the information long enough to weigh it, make a decision, and communicate it to us. If she is able to understand, retain, weigh, and communicate her decision, then she has capacity. Anyone who is trained to do so may assess capacity. It should be the person with the best understanding of the decision being made. For example, a social worker for financial decisions, or a doctor for medical decisions, and so on. Our patient had delirium due to hypercalcemia. She wasn't able to retain the information long enough to weigh it at first. She was helped to be able to make a decision by optimizing her medical treatment. After treatment, she was able to understand, retain, and weigh the risks of going back to her own home. She was discharged with a package of care to help her with meals. If you are interested in learning more about delirium, you might like to take a look at our mini-gem, Managing Delirium Out of Hours. Our case showed an example of removing barriers to understanding, retaining, weighing, and communicating a decision by treating a medical problem. Other ways of removing barriers are by correcting sensory impairment, providing interpreters, or using specialist communication aids. Capacity assessment provides a snapshot of someone's decision-making ability, so it may fluctuate and need to be tested several times. Remember that capacity is decision-specific, and if you are not sure, ask for help. Even experienced consultants ask for a second opinion sometimes. If, despite all your efforts, your patient lacks capacity to make a decision, then the decision should be made for them in their best interest. In an emergency, this can be done by the doctor treating the patient. In non-emergency situations, it's good practice to have a best interest meeting. This should include the patient if possible, and someone who knows them, such as a relative or friend. The meeting should choose the course of action which is the least restrictive for the patient and should take into account the patient's previous beliefs and wishes. For example, if someone wants to go home but struggles with self-care, a trial at home with support may be less restrictive than residential care. Sometimes the only way to treat someone who lacks capacity safely is to deprive them of their liberty, for example by restricting their movements on the ward or in 24-hour care. If this is necessary, the person lacks capacity, is over 18 and not sectioned under the Mental Health Act, a deprivation of liberty safeguard assessment should be arranged. DOLs last for 12 months and are the responsibility of the Health Board. Most trusts will have someone appointed to initiate this process. In Newcastle University Hospitals Trust, this is the MCA DOLs lead. If someone dies whilst under a DOLs, the coroner must be informed. There are some special situations to be aware of when assessing capacity. If the patient lacks capacity but has appointed a lasting power of attorney for health and welfare, then that person should make the decision in question on the patient's behalf. Similarly, if the patient has a valid advance decision to refuse treatment, then this must be followed. Both of these must be in place before the patient loses capacity. People who lack capacity, but who do not have friends or relatives to involve in a best interest meeting, should be appointed an independent mental capacity advocate to represent their interests. So let's recap. There are 5 principles to the Mental Capacity Act. Capacity is assumed until proven otherwise. People must be helped to be able to make a decision for themselves. People are allowed to make unwise decisions. If a decision is needed for a patient who lacks capacity, then it should be made in the patient's best interest. And if making a decision in someone's best interest, you should choose the least restrictive option. There are 4 steps to capacity assessment. Patients must be able to understand, retain, weigh, and communicate a decision. Thank you for listening. Here are some resources that I hope you'll find useful.
So that bit is the overall concept of the Mental Capacity Act. Now, what we've got on the next few slides is each principle with a little bit more detail if you wanted to go into it. So we talked before, for example, there she explained, well, people are assumed to have capacity unless proven otherwise. So if you think of any clients that you work with and support who have dementia, they may, do you ask them what they want to wear? Do you ask them what they want to eat?
Yeah.
Yeah, I'm guessing that they've got the ability to make decisions, and you can have days where their capacity clearly is present, and then
Yeah.
you might come into the room and out the room, and then go back in, and then all of a sudden the potentially the conversation is almost nonsensical. They might not be able to retain information. So would you say the patients you support have fluctuating capacity?
Yeah.
And what the sort of like the key concepts and principles of mental capacity and restricted practice are based on things like this. So we must always presume that capacity is there unless proven otherwise. We need to, principle 2 is looking at supporting people with decision making. So a client can make unwise decisions. They're allowed to do that. That's within their rights. But we should be trying to give them something called informed capacity, which is basically if I give you all the information and the facts and the education, it's then up to you to what you do with that information is up to you to make a decision. Does that make sense?
Yeah.
Yeah. Okay. As I say, the PowerPoint is in Quals Direct, so you're welcome to revisit and go through this again.
Just a minute if you come in.
Oh yeah.
Okay. Shall we please?
Oh, hello. You okay?
Yeah.
You really good? Okay. So unwise decisions are something that a client can make as well. So it could be a client might decide they want to put lots of money on a bet. And if they've got the mental capacity and all the independence to do it, then obviously we can do things like advise them against it. But unwise decisions are up to them. But we have to make sure we're reporting and recording and let our office know just in case. Okay. The other things is any decision we make must be in the best interest of the client. So it's not about, what does Vera want? It's about what does client A, B, C want from this? What works for them? What's going to help them in the long term? And when we talk about conflict in the workplace, this is when you tend to get a bit of conflict, is because different people will think different things are in the best interest of a client. So, okay, let's go there. Okay, and finally, we've got something called the least restrictive option. So when we look at mental capacity, a lot of things when we talk about like mental capacity decisions tend to be this idea of when we put into practice things that will, from an outside source, look like we're taking away people's freedom. And it's not about taking away people's freedom in a way that's there to cause them harm. It's all about working for their best interests. So you'll hear someone talk about the less restrictive option, okay, not the least restrictive. So by the less restrictive option, what we mean is if you have a client who, for example, keeps burning themselves because they go and make themselves a hot drink in the kitchen. Now, you obviously want to safeguard them for their best interests to make sure they're protected. But you wouldn't just close the kitchen and lock it up so they can never get into it. So what you would then have to do is, what is the one thing that we need to do in order to make sure this person is safe without going over the top? So you might hear people talk about a word called proportionality. So I do what I need to do, but no more and no less. So for example, if, as I say, you got this person in the kitchen, they burnt themselves, right, it wouldn't be appropriate for me just to say, right, the kitchen's shut, you're never going in, you've got no access, and taking away their ability to use the kitchen. However, what I could possibly do is have a special, like buy a special kettle for them, or restrict their access without supervision. So it might be you're allowed in the kitchen, but only when you've got this particular member of staff about. So it's just about making sure that we're not taking away people's freedoms and individuality unless we absolutely need to. Is any questions on that bit, or does that sort of make sense?
No questions for now.
Okay. Sorry if I'm boring you. Okay. So we've got a little bit of information here just to show you how you can go under mental capacity decisions. This is more for like an office or management setting. So from the level 3 perspective, it's more about understanding the concepts and ideas that come behind it, not necessarily how to specifically do the form. So if we go here, key concept definitions. So least restrictive, an approach that allows individuals to maintain as much freedom and autonomy as possible while receiving care or support. Best interests, a principle for making decisions on behalf of someone who cannot decide for themselves, but the focus has to be on their welfare and wherever possible their preferences. And then we've got things like valid consent. So an agreement given by an individual that is informed. So they know what they're making a decision based on information they've been given. It's a decision they've voluntarily made, and it's made by someone with the capacity to consent. We then have the key legislations and codes of practice. So as with any area of mental capacity and sort of practice, there's not just like one law. There's lots of little individual ones that will come into impact. The main one we have is the Mental Capacity Act, and it essentially establishes a framework for assessing and supporting individuals who lack capacity. One of the things that are covered are the 5 principles of safeguarding that we've just quickly gone through them. So if you have any questions when it's talking about what are the legislations and what are the key points, this is where you need to visit this page, and it will very briefly tell you some of the information, but you might need to go into it a little bit further and say add like a working example. Okay. Other areas that you could also include are things like data protection, because just because someone has a mental capacity issue does not mean that their information can be just given out to anyone. You've got DOLS, and you've also got liberty protection safeguards. So again, these are all things which, if you're going to be in a position where an organization may have to restrict certain liberties of an individual, again, it's going to be under the mental capacity decision, and liberty protection safeguards are also prevalent. But these are the different laws that sort of touch on what you do. You okay with that part?
Yeah.
Okay. Okay. Factors.
Sorry.
It's all right.
Just trying to get something.
It's all right. You keep it keeps looking like you're walking through the walls because you've got the setting on.
Yeah.
Okay, so
No time.
yeah, if we look at the factors impacting mental capacity, so you look clearly at things like learning difficulties. So someone who may struggle to retain information. You might have mental health conditions, for example, where people might suffer with depression. Stuff from my side or your side?
Guys, yeah, from my
Okay.
side.
Okay. You might have
I'm
things like,
trying to, I'm using the microwave over here.
don't
Do you
worry,
want me
don't,
to
okay.
mute myself so that
Oh,
it
no,
doesn't?
no, no, don't worry. I'm all good. Um, okay. So we've got things like mental health capacity issues, but you've also got things like mental health issues that might impact people. So things like where it might impact their ability to process information or make appropriate decision making. Substance misuse also falls under that. So if someone's had a drink or are under the influence of drugs, it could impact their ability to make decisions. But when we look at capacity, an example I tend to use is I ask people if you've got children or you have young, like younger brothers or sisters or nieces and nephews, look at the idea that you wouldn't let them play with a knife. Yeah. Or why wouldn't you let them play with a knife? Well, because they don't understand the danger associated with it. So it's the most basic way I can think of how to put mental capacity in play. Other things might have environmental stresses. So putting people on the spot might make them rush their decisions. Um, cultural factors. So here, what we're looking at is almost how someone's background might impact their decision making. For example, you could have someone who is influenced like by peer pressure. Yeah. So I can't make this decision for myself because I'm supposed to ask my elders, yeah, or I need permission from parents, whoever it is. But it's all of these things that can come into contact with our job. Um, so you need to consider these aspects. Um, okay. I know your microwave might be going off, but any questions on that bit? Or is that all okay? Little thumb up will be fine. Okay, I'm gonna guess no questions then. Okay. Um, so if we look at what your role and responsibility is for things like mental capacity and restricted practice, you've got to consider that firstly, you've got to have a understanding of what restricted practice is and what mental capacity is. Because in your job, you need to be able to recognize if you're working appropriately with mental capacity or if you're putting someone in a position where you're restricting their liberty without realizing. So for example, I've done things in the past without realizing that they were actually restricting someone's liberty, and I could have got myself in trouble. But understanding the legal framework and the basic concepts, for example, like working in someone's best interests, assuming someone has capacity, are all massively important things. Not taking it for granted that because someone is deemed to have capacity issues, that they can't make any decisions. That's where I got myself in trouble. I used to work with a gentleman who had he had some learning difficulties, and unfortunately, what happened at that particular location is there were a lot of staff who kind of assumed things about the client because they perceived that, oh, you can't retain information or you can't make decisions because you haven't got the capacity. Yet he was actually fiercely independent, but because of communication difficulties, he couldn't really tell you what he wanted. So we had to come up with solutions and work around that. But when I started, I think most of the staff probably worked in a way that was a little bit restrictive. And it sort of shows some of the challenges that we've got. Our role is also to promote autonomy, so decision making, empowering individuals to make their own choices wherever possible. So you mentioned before, client with dementia. Okay, what do you want to wear today? Yeah. Being mindful of their condition now, you also need to consider the person-centered principles. So if you ask a client who has some capacity issues, what do you want to wear today? It might be too open a question, which could then cause like anxiety. Whereas you might make a smaller choice, in which case you might come up with 3 or 4 items of clothing and go, what would you like to wear today? So it still allows someone to have choice. It still promotes their independence, still respects their individuality, but it takes into account some considerations of kind of mental capacity. Because I've worked with people that if you give too much choice, it can overload people. It can really make them struggle. I don't know if you've experienced that before. Have you had that kind of situation happen for yourself in your job?
Yeah.
Yeah. Okay. So how do you overcome that though?
Well, like you said, when I realized it, what I so
Don't worry about the microwave. There's no wahala here.
so
Five minutes ago, I was eating mine, so don't worry. It's all good.
so what happened was after reading about the client, she was a new client, and
hmm
when I got there, at that very point, she was so confused where to go to the. She wanted to use the toilet. Let me use it that way.
hmm
Unfortunately, she couldn't find her way, and then she did it on self. Some
Okay.
are mild dementia, kind of.
hmm
So sometimes they remember things, sometimes they forget things. This time around, she forgot herself, and then I don't know what happened. I think she came back to her normal self, and she realized she had done a pull on herself, and
Okay.
she was so confused. She was like
Mhm.
so down. She felt
Yeah.
so ashamed for doing that. But I had to encourage her and go like, "Oh, that's fine. You shouldn't
Yeah.
worry.
It's
It's
yes.
normal."
Yeah.
And she kept saying, "Oh, I'm sorry. I didn't
hmm
know. I didn't even know I was doing it and all that." But I had to encourage her. I just took her to the washroom, made sure she was fine. Then
Yeah.
I got her back and she was like, "Oh, thank you." She
Yeah. It's
felt
good.
refreshed. But
Yeah.
all the same, she somehow she get confused along the way. I had to like talk to her. It wasn't easy, but
Yeah. And
that's the
and
nature of
it's
the job.
yeah. It's quite a tough bit because I've worked. I've worked with someone, for example, in the past when we look at mental capacity issues, it can impact people in so many different ways. For example, people with capacity issues may decide, well, I'm gonna try and get up out of bed and walk. And it's someone who's at a risk of falls. They don't have the physical strength to walk and weight bear, and all of a sudden they're trying to chuck themselves out of bed to go for a walk because what you
Yeah,
said before, you
yeah,
said in the head they're going, well, I'm 14 and I can run round and I can do this, that, and the other,
yeah,
and you're like, you're
I
not
remember.
Barbara, you're 92 and you can't.
I remember such scenarios. It was about a husband and wife. The
Hmm.
husband has a stroke, and
Yeah.
he kept calling the. So when we got there, the wife was crying. She was so
Hmm.
agitated, and she was like, "Well, she was like, my husband said he wants to get out of bed. I've tried to convince her she cannot do it,
Yeah.
but he said he can do it."
Yeah.
And I really saw. I felt so bad for her.
Hmm.
When we got to the client, he was like, "Do you know what? I just want to get out of this bed and walk
Hmm.
around. I'm just tired staying in the bed."
Yeah.
We were like, "Oh yeah, you can. But are you sure you can get down?" But
Hmm.
what we did was he told us to put the bed rails down so that
Okay.
he can get out of the bed. So we intentionally did that, and then we were
Okay.
like, "Okay, you are ready to go. Get up."
Yeah.
And he was struggling
Okay.
to get up because he couldn't, and we were like, "You know what? It's not like we don't want to help you.
Yeah.
Unfortunately, you know your condition. You cannot walk
Yeah.
for now, so you just need to calm yourself down." Like we
Yeah.
tried,
Excellent. Excellent. And it's
talk to him.
it's it's a really difficult thing because um, restricted practice, which, for example, your bed rolls. Sorry, not your bed rolls. Your bed rails. Your
Yeah,
bed rail is an example of restricted practice
yeah,
because you put those bed rails up and the client can't get them down, and
down,
it
yeah,
and it and it keeps him in bed.
yeah,
But
restricted. Yeah.
but why do you do it for him?
Well, we tried to convince him that he cannot do it, but he believed he
Okay.
could do it.
Yeah,
So
but
we had to let him.
why does he have the bed rails though? Why does he have the bed rails?
What does he has the bed
Yeah,
rails
why does he have bed rails?
to prevent him from falling?
Okay, so are you doing that to be nasty or are you doing that to protect him?
Well, we were. It's not like we knew he
Th-
couldn't get out,
I'm not
but for
accusing
him
you.
to believe us,
Yeah.
I know it wasn't right, but for him to believe us, we were like, okay, because he
Okay.
kept insisting, take it
Okay.
down, and he was fuming.
Yeah.
You could
Okay.
see he was red all of a sudden.
Yeah. Yeah. Okay.
So you could
No,
see
I
how
I understand that bit. Don't worry. I'm not trying to dig to get any trouble. Don't worry.
okay. Was
But
it was
funda
it a bad
but
thing to do?
okay. No and yes. I
I know it's yes
yeah.
and no.
Okay. So no, because I understand what you're trying to do. You're trying to do it for the right reasons.
Yeah,
Potentially no, though, because you just said something. You said, I know it wasn't right. So as soon as you say it wasn't right, it's because you'll have more info. You probably know that, hang on, there's a care plan that says this, this, and this. So we're not
yeah,
supposed to. So while I say no and yes, there's certain bits that were positive. There were certain
and
bits
the
that maybe
negative.
could have been
Yeah,
done better.
we
But
always
yeah.
make sure it after he couldn't he after he was struggling to get out. We were
Mhm.
like, you see, this is the reason, and then we pulled the bed rails back
Yeah,
on.
yeah. You were like,
Yeah,
told
we
you
didn't
so.
leave it down. I'm sure we didn't want to
Yeah,
be in
okay.
trouble, so
Okay.
we just wanted to for him to
So
know that, oh, okay, he said
so
what you
what
said is true, just to believe us.
Okay. So what
Yeah,
you're saying is the bed rails are there to keep him safe.
restricted. Yeah,
Okay. So it's to restrict him in a positive way, though, because fundamentally it's a restriction with his best interests at heart. You're not putting those bed rails up to be nasty. You're not doing it to be mean. You're purely doing it because you know if he doesn't have them, his capacity issue means he's going to try and get up and hurt himself. So, have you heard the saying, "You've got to be cruel to be kind"?
yeah.
Yeah, that's what it is. That's best interests. Rule to be kind. Yeah. Sounds like a silly way of doing it, but that's
Because
that
sometimes it's like the family had to come in, talk to him,
yeah.
and sometimes they go like, okay, now get down, because it's like I feel like they just get fed up.
Yeah, it's a really like it's a bizarre thing, that restricted practice, because there's two parts to it. It can be legal and good, or it can be
Yeah,
illegal and highly bad. So I've done both versions of it. Okay, so for it to be legal, it has to be both legally and morally justifiable.
yeah,
So if you put the bed rails up for that man and I walked in, I'd be like, well, it's in the care plan, it's signed off, and it's being done to protect him.
yeah,
On the other hand, if I walked in and I went, he's got capacity, you're just doing it to stop him getting up and about, and there's nothing in the care plan, I would then say, you're just doing it to be lazy or to be abusive.
yeah,
So the context of the situation is really important. So when you asked before, was it right or was it wrong? Well, the bed rails are there for a good reason. Your What you were trying to do was, I would say, is give him information to help him make an informed decision, which was, we're not, these bed rails are here because you can't do it safely. And then, as you say, you're trying to reason with him. He's not taking it, so you might have needed to educate him. It's a bit of a risky one, though, I will say
yeah,
that.
yeah. Well, we
um,
were guided though.
yeah, okay. Well, as I say, just moving forward, speak to the office and get advice from them first, because had they advised it and something gone wrong, you protect yourself.
Yeah, I
If
know.
on the
That's
other
why I
hand,
said
if
to
on
them,
the other hand you didn't ask them and you did it of your own accord and something went wrong, it then falls on you. So keep your street smarts on.
yeah,
um,
we learn
but
every day though.
absolutely. I'll be honest with you. I've done probably more. I've worked in a setting which worked with people with challenging behaviours.
Mm.
I've had to do everything from hold doors shut because someone's trying to break through it to punch me. Um, technically, technically, that could be classified as restricted practice. Why was it done? It was done to stop me being assaulted. It was also done to keep the patient as safe as possible, because had they got through there and attacked me, I would have had to use restraint techniques.
Mm.
So could I have justified it? Not when I did it, no. I wasn't confident enough to explain what restricted practice was. I would have been able to say I had to do it, but I wouldn't have been able to justify it legally. Whereas now, with a better understanding, as you say, you learn from your mistakes. Now I'd be able to say, well, look, in this case, I had no other choice. I was working in the best interest of the client by protecting not only myself, but protecting the client. Because had they got through and started attacking me, I would have been in a position where I would likely would have had to use restrictive practice even further. Um, so it's you've got, but again, as I said before, there's got to be a legal justification and a moral justification. I wasn't holding the door to be nasty. I was fundamentally I was doing it to keep everyone safe.
Mm.
Um, okay. Again,
How many minutes more to go?
I'm trying to kind of push it through a little quicker because we're covering it.
Just
Um,
2 minutes. I need to sort something out now. Sorry.
okay, no worries, no worries. You're gonna get your lunch. Bless you.
Okay.
You okay to carry on? Okay, excellent.
Yeah.
Right. So when we look at mental capacity restricted practice, what we also need to look at is consent. Okay. So with consent, we obviously need to make sure it's clear that we're getting it. We need to be making sure we're acting in the best interest. Report and record if a client can't give consent or is refusing to give consent or declined. Okay. Okay.
Yeah.
But what we should have is something called informed consent. So it's me giving you the information so you have the ability to make a decision for yourself with appropriate information. Not me just saying, right, choose this, yes or no. It's you got this option, which if you choose this option, you got this, this, and this, or you could do this. So it's things, I think the most simple way of describing it is you're supporting a client to get dressed. They don't know it's raining outside, but they're going out for the day. Okay. An informed decision would be to advise them what the weather is like outside. And then they might be able to pick clothes based on that information. So they might be going, I want to wear shorts and a t-shirt, and you're looking, going, are you mad? It's are you all right? It's 4 degrees outside and snowing. So it's about just making sure the person has informed consent of being given the appropriate information. Okay.
Yeah.
We also need to consider things like unconscious bias. So making sure you're not letting your personal feelings cloud your decision making.
Okay.
Okay. So for example, an example of unconscious bias is a hiring manager who unconsciously favors candidates with names that are perceived as more familiar or typical in their culture. For instance, if two candidates have similar qualifications, but one has a name that sounds ethnic, the manager might unintentionally lean towards the person with the more common name, believing they would be a better fit for the company culture, despite the qualifications being equal. This bias can lead to a lack of diversity in hiring and limiting opportunities for qualified individuals. So it's all these ways that things get into our head without us realizing. So we've got to make sure we're self-aware and not allowing our bias to take over. Okay. Other skills and strategies that we need to consider. Person-centered approaches. Yeah. I think what you said with the lady who had the toileting incident. It's okay. You're all right. Don't worry about it. It's like, well, can you imagine if you turn around and gone, oh, that's disgusting. I can't believe you did that. You're a grown woman. How do you think she would have responded to you then?
Your line is breaking. I don't know if it's the network.
Okay. Okay. So you mentioned about the lady with the toileting incident, and you showed those person-centered values by engaging with her, showing empathy. However, how do you think she would have reacted had you turned around and said, "Oh, that's disgusting. You're a grown woman. You shouldn't be doing this, that, and the other."
Probably
You
she
know,
would have called the police on me.
call the police. Yeah, she might have thrown what she had done on it at you. I imagine she would have found the office.
Yeah.
Yeah.
Maybe that might not come in first
Hmm.
because it takes process. She might go, I'm going to call your office to tell them, boy, I need to call the police on you or something,
Yeah.
Just
Okay.
any of them that she thinks might be saying for her. Maybe the police will come in earlier than you.
Yeah. Yeah. Obviously, need to make sure with anything we follow our policies and procedures, but within our interactions with the client, we also need to make sure we use the use of plain language. So
Yeah.
we're not using slow jargon.
Wearing words.
Yeah, yeah. I think it's a horrible term, but I've heard people talk about keep it simple, stupid. And it's the idea that if you say it in such a basic way that everyone can understand, that it doesn't overcomplicate things. But if you've worked, for example, with people with dementia, you may see with your communication, if you talk too much and say too much, they may struggle to process the information. Okay. Giving people time to reflect on the information you provided them. And again, gathering any relevant information you might need to support you and the client with their capacity and decision making. But it needs to be reevaluated all the time. So with regards to dementia patients, if you've got someone who's got early onset dementia, it could be that they're a little bit forgetful every now and then. You might not even notice really. And then you might work with someone whose health deteriorates to the point where it really starts to become very challenging for them. In which case we need to make sure we're updating and keeping everyone informed of changes like that.
Yeah.
Okay. Other skills we need: active listening, empathy, patience, critical thinking, the ability to analyze information and consider the context before making a judgment about capacity, clear communication, and accurate record keeping. Yeah. You okay with that bit?
Yeah.
Okay. What are you eating? What have you got?
Restrictive.
What have you got?
Sorry?
What have you got for lunch?
Oh, banquet and okra stew.
Okay. Nice.
That's a
Never.
Ghanaian dish.
I was gonna say I've never heard of it. I was like, oh, lovely. Yeah, okay. I'll have to Google that one. Okay. So I know we've sort of briefly touched on restricted practice and gave the example before of the bed rail,
Yeah.
but there's a couple of other ones you can get. So your bed rail is an example of physical restraint. So physically they can't be free. You've also got mechanical restraint, which can include things like putting on seat belts or straps onto, say, for example, a wheelchair so the client can't remove them. You've got chemical restraint, where if I gave a client so much medication that they became almost vegetative and sedated, that they've literally just sat there almost drowsy because of the amount of medication, that can be classified as a form of chemical restraint. Other examples can include seclusion, so placing a patient in isolation or even a locked room. Segregation, so keeping people away from other people. I had to do that with one of the clients I supported many, many years ago. He was experiencing some quite extreme behavior changes. Had his medication stripped from him because it was no longer appropriate for him to have it, and it was causing him some nasty side effects to his, like, physically to his body. So they had to withdraw him from his medication, and what we found is he then started becoming incredibly violent. So if he walked into a room, he would walk up to people and literally just go to hit them. So unfortunately, we were in a position where for a couple of weeks we had to keep him isolated away from the rest of the house. Very difficult indeed.
Yeah.
we didn't want to do it, but we were in a situation where his behaviours were so unmanageable, and it was really difficult time. I remember leaving work. It like I had to leave work for a break, just because I was in tears, seeing how much like everything was impacting him. But also our job is really difficult when you see someone who is going through essentially a mental health breakdown and a crisis,
Yeah.
but they're also being aggressive to other people. So we felt compelled to have no choice but to do that in his best interest and the best interest of everyone around him. But looking at it, we should have reported it so much earlier, because we put it up for 2 weeks. Within 2 or 3 days, that definitely should have been actioned. But for someone to have 2 weeks of continuing it like that, it was quite scary. Yeah. But they, as I say, there's a couple of lists there and examples of some of the different types of restricted practice you got. Again, with restricted practice, there's a little bit more information here. It's about making sure that any restrictions need to be made sure that they're clearly documented in the care plan as authorized actions. So, for example, my very first job worked in a setting where we had like restraint techniques, so with like holds and stuff. Now, holds, unless authorized, are typically very, very restricted practice. Now, for myself, when they were used, our policy was very much they were a last resort. So you try everything else that you could to de-escalate the situation before that happened. And it was also, staff were trained, and it was all in the care plan. So everything was legally written down, so we knew we could do it safely and legally. If I tried doing that at a DARDA, I wouldn't necessarily be able to have the same argument. Yeah. So if you've got someone who's potentially showing like things where there's an issue or a challenge, we need to make sure we're speaking to the office so that they can give us authorization and guidance on what we might need to do. But there are emergency situations, and that's where restricted practice gets difficult. Because if an individual poses an immediate risk to themselves or others, you might be in a situation where you might have to think on your feet and use restricted practice. So, for example, I looked after someone who decided he was going to try and jump in front of traffic. Clearly, not something that was happening on my watch. I don't want to do the paperwork for it. But in that situation, he went to go and drop to the floor, and we had to basically pull him away from the road, and then we had to do a floor hold with him. It basically had to pin him down because he kept on trying to get into the traffic. Now, technically, by legal definition, that's restricted practice because we're just restricting his liberty. It wasn't in the care plan, so it was very much a decision that we had to make on the spot. But anytime you might ever need to do that in an emergency situation, you have to be able to explain why you did it and justify it, if that makes sense.
Yeah.
Yeah, not nice stuff, but sometimes this is a necessary evil.
Yeah.
Okay. Illegal restricted practice. So things like a lack of consent or doing things without a clear medical purpose may also violate the law. Inappropriate use of restraint. So what I said there was an appropriate use of restraint. But if I was just simply doing it because I couldn't be bothered, or I didn't want them to go somewhere because I was too lazy to go and do something, then it would clearly be a totally different thing. So, yeah, all of these sort of key considerations. Are we doing the things for the right reason? Yeah. Or are we doing them for our own purpose and our own reasons? I don't imagine restricted practice is something you come into contact with a lot in ADADA. Correct me if I'm wrong. Is restricted practice something you've come into contact with at ADADA? Oh, hello. You are there. You are there. Can you hear me?
Yeah,
Okay. So
I heard you say it.
okay. So is
And you had the
restrictive
drink.
practice? Yeah. Is restrictive practice something you've come into contact with?
Yeah,
Okay. So again, it's just making sure you're aware of the processes so you can practice safely for yourself, but also the individual.
yeah,
Okay. Least restrictive, again, I think we've already sort of touched on it. So the terms least restrictive and less restrictive both refer to the degree or limitation of constraint imposed, but they mean two slightly different things. So least restrictive, it's often used to denote an approach or option that imposes minimal amount of restriction necessary. It suggests that out of all possible options, this one is the most accommodating or supportive, minimizing limitations on a person's rights. Okay. Whereas less restrictive implies a comparison between two or more options. So you've had three or four options, and the less restrictive is the one that you wait for. Whereas the least restrictive usually indicates you've done nothing. Yeah. But the definition is written there. So if you need to look through it, it's there for you.
yeah.
Okay.
Okay.
And the last little bit we've got is sources of support. So you might hear me constantly talk about referencing.
Yeah.
Yeah. Okay. These are good places to go for information for your studies and research.
Yeah.
Gonna close this down. Okay. You said you are free. Did you say Thursday or Friday? Let's have a look. Right. So if you're free next week, the
Thursday,
first. Okay.
Friday.
Okay, so Thursday and Friday. Okay, I've got nothing on so far on either of those days. So what time would be best for yourself? It should take 45 minutes tops.
I think I'll have to update you because I'm not too sure. I'll check out. I need to do something on Thursday.
Okay.
But I think 1 p.m. will be fine.
Okay. As I say, if you need to change it, just let us know and I'll do my best to swap it round. But
Okay.
what I'll do is I'll put all this on a plan for you.
All right.
With the CPD, it's talking kind of like what we've talked about before today, where I've gone, right, tell me about a time that you've done this. So it's getting you to reflect on what you've done and give your examples.
Yeah.
But as I say, when I go through the questions with you, if there's anything else I need out of you, I'll word it and get it out of you. Don't worry.
Okay. All
Okay.
right.
But
Thank you.
I'll send that over to you, and I shall, as long as everything's all good, I shall see you on Thursday, 1 o'clock.
Yeah.
No
Thank
worries.
you.
Take care. All the best. Bye bye.